Hi, this is Brian Kim. I want to share with you case number 247, the best way to do cataract surgery series. And the title of this series is not to suggest this is the best way, but to get you to think critically of your technique, finding ways to refine and hone your technique so that you can provide the very best for your patient. So this patient is a high myope, and this is a soft lens. Because this is a high myope, it's always a challenge to do Hydrus because of the reduced scleral rigidity. When you're trying to stab the device into Schlemm's canal, the reduced scleral rigidity makes it really hard to position it. And so you're going to see how I was able to perform the technique on this patient with reduced scleral rigidity in this high myope. I use a corneal marker which will help me to center and size the rexus. This is my paracentesis incision, first on the right side. And then the left side. I always recommend making your Hydrus incision early in case the patient has bleeding. You don't want any blood to get into the interface. This is intracameral epinephrine, and then some dispersive viscoelastic to coat the corneal endothelium and to flatten the anterior capsule. Again, big pupil, big eye, high myope. And you can tell when I make my incisions, there's quite a bit of reduced scleral rigidity. This is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and then when I'm ready, I enter. At this point, I realize, oh man, I should make my incision for the Hydrus. I forgot to do it before, and you can see this patient has quite a bit of peripheral corneal vascularization, and so when you make the incisions like I have, you can see there's quite a bit of bleeding. All of this is just signs to what I said earlier, that this patient is a high myope with reduced scleral rigidity. So I'll make my incision for the Hydrus. And these are the Moria sharp tip microrexus forceps. I go in sideways and then puncture the center, pulling down towards me, grabbing the right side of the tear. You can see how widely the forceps teeth open, which is really nice. Grabbing the right side of the tear, going around circumferentially, trying to match the rexus to the size and centration of the corneal mark that I made earlier. And I'm using that cannula, again, I use that cannula for a variety of reasons, but in this case, I'm using it to steady the eye so it doesn't move around. But if there was sudden loss of OVD, I can push more OVD if I needed to, in case there was some radialization forces if it suddenly occurred. Finished off the rexus. Burp some viscoelastic out. And then coating the corneal surface. I like to coat the cornea. By doing it this way, I have a nice view. I don't have to depend upon the technician to constantly lubricate the cornea throughout the surgery. This is the capsule fornix hydrodissection technique. I place a cannula under the rexus edge contra-incisionally. Get a nice wave. Gently trying to decompress the bag and put the lens back in. It tilted up sideways. There's no reason to be aggressive and try to put the lens back into the bag. So since it's sticking up quite a bit, I decided to just leave it that way. And again, I don't irrigate the surface anymore because the viscoelastic is coating it. I lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma. Since the lens is already tilted up, no big deal. I place the chopper around the lens, and then I'm sandwiching the lens with the instruments. So the lens is tilted, which is fine. I get the chopper behind the lens. I'm stabbing the lens on the anterior side with the fingertip. I'll be able to crush the lens in half, even though it's a different type of chopping maneuver. I can just crush the lens, separate the instruments, and separate the lens, and now I have two heminuclei. Slide the chopper under the rexus edge around the right heminucleus, hooking the peripheral lens. You can see I slid it, I pointed in my hand, sliding under the rexus edge, and then turning vertical again. Now I'm hooking the peripheral lens. I'm placing the phaco tip between the lens pieces within the chopped groove. I pull the chopper towards the phaco tip, crushing and bisecting the right heminucleus in half, and that is the cross chop maneuver. Using some vacuum to grab that first quadrant up, and then emulsifying the lens piece. Again, this is a rather soft lens. Trying to loosen that second quadrant up. It doesn't really want to come up. So I just hook the second quadrant with the chopper and just very carefully trying to pull it up. Again, it's cheese wiring because it's so soft. Grabbing the second heminucleus with some vacuum, which pops it right up out of the bag, and then very carefully eating the lens pieces with high vacuum. Again, this is a soft lens. Excellent control, again, even though the lens did not present itself in typical fashion. Since I know how to utilize mechanical fracturing techniques, I was able to just position the instruments around the lens, crush it in half, and then separate the lens and disassemble it. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. I always start sub-incisionally, peeling from anterior to posterior. By doing it this way, you get the cleanest removal of the cortex. The polymer tip is really very safe, and you can be confident as you're sweeping and peeling off the cortex. When you have a metal tip, you can get little barbs on it, and even though everything's going smoothly with IA, you can actually rupture the posterior capsule. I've heard of people doing that. With the polymer tip, I have zero concern that that will happen. It is really very, very helpful, and as a result, I don't tend to worry about rupturing the posterior capsule with IA. Switching to polish mode, polishing under the rexus edge, polishing the posterior capsule as well. You can see huge pupil, nice clean bag, cleaning up the lens epithelial cells and any remaining cortical material. I'm going to pulse some BSS into the subincisional capsule fornix. It's pretty clean, I don't really see much there. Disengage the fluid and then pushing cohesive viscoelastic to fill the capsular bag. It's important to disengage the fluid, otherwise the OVD will just go right out, which makes no sense. Turn off the fluid and then push the OVD in. Sweeping with the sweeper on the left side and then on the right side to remove any lens epithelial cells that are stuck to the underneath the anterior capsule rim. And this is a single piece acrylic lens. I'm going to inject it into the capsular bag. It opens up nice and slowly, so I can go in with the INA handpiece, turn on irrigation, reposition the entire lens within the bag. All right, so I'm ready for the Hydrus. I want to fill the chamber with OVD and then coat the surface of the cornea with OVD. You can see the blood in Schlemm's canal with the gonial lens in place, but then I lift and then I'm going to slide my Hydrus delivery system through my Hydrus incision. You can see I have an excellent view, but again, the reduced scleral rigidity in these high myopes really does worry me. And so the key is to be decisive. You want to stab into the anterior TM where the blood is right there. You want to make sure you're fairly flat and stab. A decisive and aggressive stab right through the TM. You can start to see blood emanating on the trocar tip. I start to advance the microstent through Schlemm's canal, and it's going in nice and smoothly. I deliver it all the way. You want to pull straight back. You don't want to lift. You might rip the TM. You don't want to do that. So you want to withdraw back and then use the tip of the trocar to just push at that indentation spot of the Hydrus microstent to advance it a little bit more. And then repositioning the microscope. I'm going to make sure I look again. And you can see beautifully that the Hydrus is fully within the system in the Schlemm's canal. You can see all the windows, and I'm good to go. So I go in with irrigation off, activate irrigation, get underneath the lens, removing all the viscoelastic from within the bag. You can see there's quite a bit of heme, which again is confirmation that I'm in the right position. Lifting the iris because there's a little bit of reverse pupillary block. I'm going to polish under the rexus edge, removing all the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is another soft lens. You can leverage mechanical fracturing forces to flank the lens with the instruments, with the chopper and the ficca tip, crushing the lens very systematically, very easily, and precisely, because you're leveraging just mechanical forces by crushing the lens into smaller and smaller pieces, and then performing the cross-chop maneuver, hooking the peripheral lens, and then pulling it centrally toward the ficca tip and crushing the lens against the ficca tip like a chopping block. And then again with the Hydrus, I made my incision early on, beginning of the case. There was a lot of heme coming from this high myope. The peripheral corneal vessels was bleeding, but because I made the Hydrus incision early on, I did not have any interface fluid, so you didn't see any blood mixed with the OVD for my gonio lens. It did not obscure my view. Everything went really, really well. And then you have to be decisive. When you have high myopes with reduced scleral rigidity, you have to have good view, make sure you have an en-face view, stab through the anterior TM, making sure you're fully engaged, because when you don't do that and you're not decisive, it can just slip because of the reduced scleral rigidity. As you push, the sclera will just kind of bow back. You want to stab it decisively, position it, flatten out, advance the Hydrus, which went in perfectly in this case. And again, at the very end, you saw a lot of heme coming out just to confirm the position, and this patient did very well. So I hope this was helpful to you, and I thank you for your attention.